Thank you, Dr. Suman. Bismillahirrahmanirrahim. Heartfelt thanks, particularly to Dr. Gurudutt Gupta, who has taken pains to assist us, give us our knowledge. We will be entitled from his lecture. As you have heard from Dr. Suman, that we are organizing this after meeting regularly. Today we are starting GI malignancies. Our participants will be happy to learn. They will get chance to hear from a person like Dr. Gupta. On behalf of the members of the Oncology Club and myself, heartfelt thanks to you and all the participants for coming here and joining our session. Thank you all very much. Now I declare this open, inaugurate this session. So you continue, Dr. Suman.
So thank you, sir. May I request Shorna to start the poll? Shorna, over to you.
Yes, sir.
One minute for one poll, okay?
Okay, sir.
I'd like to request all the participants to participate in the poll. As you know, this is nothing like examination. This is just for fun.
I can't participate.
Okay, even you can participate, sir.
Showing.
একটা মেসেজ পাঠাইছে দেখ Suman, Dr. Sunil also joined with us. Dr. Sunil Parsikar also joined.
Sir, do I move forward to the next question?
Hello,
Welcome,
sir.
Dr. Sunil. Good to see you.
Hello, Sunil.
Thank you. Hello, sir.
Hello.
Hello, good to see Dr. Shunil. Okay, I think we should proceed to the next poll, next question.
We missed the first poll, Shun bhai.
I hope you will join in the later part in the next session. Thank you, Shona. Next poll. Thank you, Shona. Last question. Thank you. So thank you for joining in the poll. Now I would like to request today's speaker, Professor Gurudutt sir. Those who join later, just for them, the introduction, very short introduction. Gurudutt sir, working as a senior consultant and head of department is histopathology department, Rajiv Gandhi Cancer Institute. Besides sir, there is another overseas faculties that is Sunil Partisha is a very known face in oncology arena for oncology club. He's also here and he will be as a overseas faculty in this session. So without any delay, I would like to request today's speaker, Gurudutt sir. Over to you, sir. Sir, unmute yourself, sir.
Please unmute.
Thank you, Dr. Mustafa. Share my screen. Yeah, screen is visible?
Yes.
Okay, sir. Yes.
Yeah. Good afternoon, everybody. Thanks for the kind word. And I'm not a professor. I'm a practicing pathologist. So my topic is how pathology can guide treatment, molecular subtypes, HER2 testing, MSI, EBV and PDL1 in stomach cancer. It's a good initiative because I think I'm hearing for the first time the stomach has been taken up because as such it is not very often discussed. Usually we discuss liver or ampullary, pancreas or go for neuroendocrine. So I think this is a good initiative. So introduce the subject. We have in Asia more incidence of gastric carcinoma compared to Western world. So it is sixth most common cancer in India. Globocan 2018 survey shows that. And stomach carcinoma, the incidence in India annually is 57,000 cases. It is fifth most common malignant tumor in India, third most common in males. In females, it won't figure in top 6. Third leading cause of cancer-related deaths in the world. So it is quite shocking. And 5-year survival is still dismal at 29% worldwide. Now, we have to understand what is the distal part and what is the proximal part. So the distal part includes the antrum, the pylorus, and for this definition, they include corpus also because mostly it is enteropyloric and with involvement of corpus. Whereas the proximal are cardia, the junctional area, and fundus. So in high incidence areas like us, 80% are distal, and in Western world, 50% are. Just hold on, I'm actually seeing this messages, admit and all those.
Don't worry, that we will take care. Your guests will come and it will go. No problem.
Yeah,
That
yeah.
is the-
Okay. Okay, thank you, sir. So in Western world, 50% are proximal because they have low incidence of H. pylori. 90% are sporadic, 10% develop in familial hereditary setting. And as we all know, H. pylori is most common cause of non-cardiac GC. Oh, now I can't. Oh, yeah. Now coming to histological classification, the first classification was given by Lauren in 1965. It is still used and it is still relevant. The 3 main types are intestinal, diffuse, and mixed. This is used in WHO also. And in the 2019 WHO, 4 main types are given. That is papillary, tubular, poorly cohesive, mucinous, and mixed, and other histologies. So first we'll see the common types. The tubular type shows, as the name suggests, well-formed tubular glands, and papillary will show the papillary architecture, and diffuse type will show diffuse infiltration of tumor cells in the lamina propria reaching up to serosa, and the signet ring is a type of diffuse. Now, tubular and papillary, why they are still important to know these, they have propensity to spread by hematogenous route. They are more often causing liver metastasis, whereas diffuse type, it permeates the serosa and it causes the dissemination in the peritoneum. This micropapillary is a uncommon type in stomach, and it is an aggressive tumor with more often having lymph node metastasis. Now coming to other histological types. This upper panel shows the hepatoid adenocarcinoma spectrum. On the left is the hepatoid adenocarcinoma. On the right is the enteroblastic carcinoma. These are both hepatoid adenocarcinoma spectrum. They are unique because they have alpha fetoprotein expression and they have stem cell features, and they can be identified morphologically and in addition by doing stem cell marker ISC, like you can do SAL4, Claudin 4, and glypican 3. And one important point about this type of cancers is alpha fetoprotein levels are increased in the serum. So that has to be kept in mind. Now, lower panel, this is funding gland type carcinoma, adenocarcinoma. These are now good prognosis tumors because funding gland type carcinomas, usually they are seen up to mucosa and usually lymph node metastasis is not seen. Now, the last type is carcinoma with lymphoid stroma. These are seen in EBV subtype, that is, they are EBV positive, they have EBV infection, and MSI type. So they both have good prognosis. So accurate classification is helpful. That is, histological diagnosis should be accurate. We get small biopsy, it has to be diligently seen, diagnosed correctly, subtyped properly, and treatment and prognosis can somewhat be predicted. However, patient outcome is difficult to predict using only the classic histologic criteria because all the Lawrence classification or the WHO 2019 will not correlate with the prognosis. And traditional histological classification has limited use in guiding clinical outcomes. So progressively, they have switched over to molecular classification. They have investigated, and TCG and ACRG are the two major publications in this step. Now coming to molecular pathway. We all know this model, Korea model for intestinal type gastric carcinoma. Now, normal gastric mucosa, which is CDX2 negative, when it gets this H. pylori infection, leads to chronic gastritis, progresses to atrophic gastritis, then intestinal metaplasia, develops adenoma or dysplasia, and then the gastric carcinoma when it the axis APC beta catenin axis amylase methylation occurs. So it develops into intestinal type of gastric cancer. Now, normal gastric mucosa, when there is hereditary diffuse gastric cancer, loss of heterozygosity of E. cadherin and the tumor develops. Similarly, from atrophic gastritis, the P53 mutations lead to diffuse gastric cancer formation. Now, this was a Swedish paper, quite interesting. 20-year gastric cancer risk in patient with particular gastroscopy findings. So if you see normal mucosa, the chances are 1 in 256, gastritis 1 in 85, atrophic gastritis 1 in 50, intestinal metaplasia 1 in 39, and dysplasia 1 in 19. So this is a message for pathologists that we should report dysplasias, metaplasias, atrophic changes, and gastritis very diligently. This Carnerio model for diffuse type, it is not very inclusive, but it is quite accurate for germline mutations. So what we get is in situ signet ring cell carcinoma with early pagetoid spread in those carriers, and then they develop into signet ring carcinoma with early invasion, that is few cells, they go into lamina propria, then finally it develops into signet ring cell adenocarcinoma. Now coming to molecular classification of gastric adenocarcinoma, this review published by Wang et al. In 2000 19 is very informative. So I've used this. The molecular methods used by all the various schema are next-gen sequencing. So they did all the DNA sequencing, RNA sequencing, whole exome sequencing, copy number variation analysis, DNA methylation assays to finally classify GC into various molecular subtypes. So in 2011, it started. By 10 et al., they gave the expression profiling, that is genomic, intestinal, genomic, diffuse. We'll see details in next slide. In 2013, Lee et al., they gave proliferative, metabolic, mesenchymal types. In 2014, TCGA gave the 4 subtypes that we commonly use: EBV, MSI, then gene stable, chromosomal instability, that is CIN. But however, this was based on Europe and USA population. In next year, the Asian Cancer Research Group, the ACRG, they published their classification. They also gave 4 subtypes, that is MSI, microsatellite stable, that is MSI as one group, then MSS, that is microsatellite stable. Now in microsatellite stable, it is EMT transition, then MSS, TP53 active, and then TP53 inactive. So these are 3 types of MSS. Now this was based on Asian population, Japan and Korea. Now this is intrinsic subtypes. And in this, the intestinal type had superior overall survival, mostly intestinal histology, and they responded to 5-FU and oxaliplatin. Whereas diffuse gastric carcinomas, they were more sensitive to cisplatin, and their overall prognosis was poor as expected. The second system, the Lee system, the proliferative, metabolic, and mesenchymal GC, as we all know, mesenchymal is diffuse, so it has poor prognosis. Metabolic GC was intestinal, and proliferative marker, low TP53 mutations, more sensitive to 5-FU treatment, and proliferative GC, high number of P53 mutation and shorter disease-free survival. Now, the relevant classification is TCGA classification. This is more relevant and important. So, in this, the EBV and MSI had the best prognosis. However, EBV was the least common, and they had PDL1 overexpression. So this was important. So it can be targeted by PDL1 checkpoint inhibitors. Similarly, MSI, they are more, they have gastric sim, that is CpG island methylator phenotype. So, and MLH1 silencing because of that, and this also can be targeted with PDL1. Now, very important thing is to remember that these MSI tumors, they do not respond to adjuvant chemotherapy. So that is why upfront, when a cancer patient, the GC patient is diagnosed, we should check for MSI. Now, coming to gene stable, these were more diffuse histology. They had this CHD1, that is E-cadherin loss, RHOA mutations, and rare TP53 mutation, and chromosomal instability pathway. They had more intestinal histology, more junctional area they are present, and they have this RTK RAS activation, that is tyrosine kinase pathways, receptor tyrosine kinase pathways are activated. So the potential targets like RTKs, EGFR, VEGF, and CDK6 can be used. In these cases, they are not actually still approved, but they can be tried, other than VEGF, which is used. This is the original article published in Nature. So this is their analysis. So we can see here that EBV type is enriched in mitotic pathways, and gene stable in cell migration, that is CDH loss. So this picture is used everywhere. So EBV fundus body, MSI more in antrum, gene stable all locations, chromosomal instability with intestinal histology more common in junctional area and cardia. Now coming to ACRG classification, this was almost similar. Now they had MSI GC, which was similar to TCGA, and it has silencing of MLH1 gene, mutation of ARID1A, mTOR, etc., and overexpression of PDL1. So best overall prognosis was seen with MSI GC. Then MSS TP53GC, this had frequent EBV infection and the prognosis was intermediate. Whereas MSS EMT more diffuse, MSS T53GC intestinal histology, they are more like the junctional tumors, intermediate prognosis, and EMT had worse prognosis, highest recurrence rate. So this was the original article which was published. This is their heat plot and the stratification. So they, at the end of the paper, they proposed to use ISC as a surrogate for this classification. So MSI by MLH1 was proposed, followed by PCR. For MSS EMT can be diagnosed by E-cadherin loss, and MSS P53 active by MDM2 negativity and P21 expression, and MSS P53 inactive by MDM2 positivity and P21 loss. Now comparing TCG and ACRG, so EBV group we have already seen that it corresponded to MSS TP53 active, MSI was MSI, SIN was MSS TP53 negative, and genomic gene stable was MSS EMT. So TGCA, SIN, and GS were present across the ACRG group. CDH1 and RHOA were rare in MSS EMT, which was seen in MSS P53 positive or negative group in ACRG. So this might be because of different population was used, that was more American, European population. This was more Asian, East Asian population. Sampling of the tumor might be different, and technology used for this study might be different. Now coming to our small study, we also did one small study for molecular subtyping of GC by ISC. So it was a 2-year prospective observational study. Informed consent was taken, hence we could include only prospective cases. 80 cases of naive gastric resection are included. We made a micro array, this type of array. It is 5 mm with 2 cores per case. So only 6 cases were included in one slide. The main work was done by my colleague, Dr. Garima Durga, and we have done all these markers, that is MMR panel, E-cadherin P53, PDL1, HER2, and EBR by ISH. So this is showing the EBR positivity, the whole array. So blue color is this one case is positive. This is PDL1 staining. 2 cases are obviously positive. So in our case, we had 36% insert, but this number is very small actually. We have to complete 80 cases, but because of this 220 pandemic, the COVID pandemic, the cases are less, so we could only gather 36 cases. So we have to extend the study. So intestinal was only 36%, diffuse 50%, mixed 14%, more like Western population. So we had to wait for more results. EBV was uncommon in our group. MSI was also lower. And this HER2 positivity was also very less, only 5%. So somewhat we have to actually do the numbers, and then we can see the results. Now, our study is based on other studies which have used the ISC for molecular subtyping. So this is one such study, Eva Maria Workman, and they have similar findings. Like MSI, HER2, and EBV were absent from diffuse type. P-cadherin was aberrant in diffuse type. P53 was wild type in EBV, and all EBV were MSI. There was no MSI in EBV group. So in their case also they have more HER2. So maybe because they have more junctional tumors, that is gastroesophageal adenocarcinomas. And SIN category had lower response, hence they are said to be cold, immune cold. This was the other study. Because of small numbers, their EBV showed the worst survival, number was low. And they proposed to use this algorithm. So PDL, ISC, and checkpoint inhibitors of first-line therapy for EBV group, MSI, that is hypermutated cases, and for others, HER2 IC plus or minus fish, and should be used. Now coming to the specific testings. Now HER2 testing in gastric carcinoma was proven by TOGA trial, which was done in 2010. So they included unresectable gastric and gastroesophageal tumor for HER2 positive cases, chemotherapy and trastuzumab with chemotherapy alone. So those two groups were compared, chemo plus trastuzumab with chemotherapy. A statistically significant increase in overall survival was observed. However, the improvement of only 2.7 months was seen, which was very small. So in post-hoc analysis, the improvement was better, 4.2 months. So as anti-HER2 therapy was approved for gastric carcinomas by US FDA based on TOGA trial. And however, it is only limited, that is very important to remember, it is only limited to ISC 3+ or 2+ with ISH positivity, that is ISH, but HER2 17 ratio greater than 2. So this fish or ISH should be positive for all cases of 2+ to give the therapy. And no significant survival benefit was seen in patients who were ISC 0 or 1+, which are categorized as negative on ISC or were only fish positive. For example, a case can be fish positive ISC by ISC 0 or 1+. It is not a candidate for trastuzumab therapy in gastric carcinoma. So it is recommended that all cases of gastric carcinoma which are considered for this therapy be tested for ISC first, and this then they should be reflexed to fish. If it is required, they are scored as 2+. And this is because heterogeneity is more in gastric carcinoma than breast carcinoma, where both can be used, but now by 2018 guidelines, now even in breast carcinoma, it is recommended to approach with ISC followed by fish. So HER2 score 0, of course, no reactivity in biopsy specimen, or weak, less than 10% tumor cells, it will be negative. We can see here. Now, this is obviously positive, strong, complete basolateral or lateral membrane positivity. Now, this is unique for gastric carcinomas that we take incomplete lateral or basolateral staining also. That is, it is not complete membrane staining around the cell because there is a luminal surface. That part is not stained sometimes. So that is why this is taken as positive when the basolateral and lateral membrane is completely stained. And for biopsy specimen, a cluster of 5 cells is enough to call it positive. So this is the algorithm which is recommended in TOGA trial. So for all patient tumor samples, unresectable advanced. IC is done, score 0, 1 plus, labeled as negative, no further testing. All 3 plus, they are eligible for treatment by trastuzumab. All 2 plus should be reflex to FISH testing. If the HER2 CEP17 ratio is more than 2, it is positive. The patient is eligible for trastuzumab. If it is negative, then no therapy should be given. Now coming to immune biomarkers. Now PDL1 in gastric carcinoma was, this is based on a paper by Liu et al. They used the ACRG group cohort samples to score for PDL1 by 22C3 clone, and they showed that EBV and MSI categories show higher proportion of PDL expression as is expected. We have seen already the molecular profile, and the MSI and MSS EMT category of ACRG. It shows high PDL1 expression. Now, mutational load and PDL1 CPS has independent predictive value for checkpoint inhibitor treatment selection. So we can use this also, mutational load and PDL1 CPS. It is highly expressed in ARID1A and PIK3CA mutant gastric carcinoma samples. However, when the multivariate regression model association was done, this association was lost for ARID1A. However, it persisted for PIK3CA. So PIK3CA is more predictive than ARID1A mutations. So this is shown in this box plot. So we can see for ACRG, this MSI group showed significance. For TCGA, EBV, and MSI group both showed significant activity. So when we are doing and ordering the PDL1 test, it is very important to know what type of antibody will be used. So for gastric cancer, if you are planning to give pembrolizumab, then ideally it should be 22C3 because that is the approval, it is the label. We use SP263 on Ventana Benchmark Ultra platform, and the scoring, when if you use 22C3 or SP263, CPS should be scored. And it has been found out that it is more informative than TPS alone. So CPS has to be scored and reported. So CPS includes immune cells and tumor cells staining. So the immune cells and tumor cells are counted as a numerator, and they are divided by number of tumor cells as denominator. Then you get the score. So for treatment by pembrolizumab, we require CPS greater than 1. Now, it is very important to use a validated assay, which is properly calibrated, and it should be scored by a trained pathologist. It is very important that whoever is scoring these results, he is trained to score by CPS. A person who is scoring by, say, for tumor cells in lung, he should get training in CPS and then only attempt a PDL scoring by CPS. So that is very important to remember. So correct reading of slides, correct reporting is required. Now response, you can refer to keynote 062, which has shown that as a monotherapy, also it has some activity. However, in combination, it was a negative trial. So PDL1 is important and should be properly scored. Now coming to microsatellite instability detection methods. Now we have already said this MSI status is very important, because when you are starting the treatment, you should know this status so that correct therapy can be selected. Now detection methods mainly are 3. First is NGS, Thermo Fisher Oncomine is used in our lab, and it gives accurate results for small amount of samples. More than 100 microsatellite loci are tested, and it has very accuracy we don't know for Oncomine, but this FDA approved test like Foundation, it has 94% accuracy. Similarly, this ProMega fluorescent multiplex PCR with capillary electrophoresis, it will tell you about the MSI status only, and it includes 5 microsatellite sites, that mononucleotide, and it is quite sensitive for MSI status, but it will not tell you which gene or whether the patient has Lynch syndrome. Now, that is the advantage of immunohistochemistry when you are using 4 ISC markers, that is MLH1, MSH2, MSH6, and PMS2. So it has a wide application. It is very comfortable for pathologists to report because they can take it in their flow, the workflow, and results are quickly available. Unlike ProMega, where you require to have patient blood or normal sample also. So it is also quite accurate up to 95%. Now, I think we can highlight one thing, that the cases which are only MSS6 deficient on ISCs can have MSS status on MSI by PCR. So this is a known fact, and some people say that such cases will not benefit, that is, they don't have MSI status, hence they will not have immune markers or this responsiveness to checkpoint inhibitor. Another modality is tumor mutation burden, which can, as we have seen, it can also be used for checkpoint inhibitor selection for the patient. Now, as we can see, stomach is having quite high tumor mutation burden. It is only preceded by bladder, lung adeno, lung squamous, and melanoma. So it is also having quite high tumor mutation burden, but usually it is not subjected to TNB. So this is done by NGS. So these are the two FDA approved.
Please unmute, sir, yourself. Dr. Gupta, please unmute yourself.
Yes, yes.
How much time I have?
No problem, sir. You can proceed.
Okay. There are two FDA approved tests, MSK Impact and Foundation Medicine Foundation. So both can be used. We are using Thermo Fisher Scientific Oncomine Tumor Mutation Load Assay, which includes 409 genes, and it measures 1.7 MB DNA. So when you are doing TNB, you are actually sequencing the exomes part and you are looking for mutations. Now, coming to stage. Now, having said all the molecular, all the ISCs, and all the tests, stage is still the single most important factor deciding treatment and survival. And early gastric cancer has best survival still. Like more than 90% survival will be seen in T1 tumors. And as you progress, like if patient is N3B, the survival falls to only 20%, 5-year survival. So stage is very, very important. So accurate staging, clinical staging is mandatory for prognostication of a gastric cancer patient. Few detected. Now, as we talk of early gastric cancer, we don't get many. We see hardly 1 or 2 cases in a year. So they are detected in countries where there is regular gastric cancer screening, like Japan or Korea, where they regularly screen for gastric cancers. For metastatic unresectable histologic type like diffuse or intestinal, it provides clue to biomarker studies. So you will go to for HER2 testing and if required NGS. Now coming to tumor regression grading. Now, this is recommended by CAP. We follow this RAN system. The choice is institutional, what type of system institute wants to follow. So there are two poles. Tumor regression score 0 means complete response, no viable cancer cells. Now, before labeling any specimen as having no viable cancer cell, complete response, we have to sample the lesion, that is tumor bed, completely, and then we label it as tumor regression score 0, which is uncommonly seen in gastric cancers. Then at other pole, we have extensive residual cancer with no evident tumor regression, poor or no response, that is tumor regression score 3. Now this TRG3 is bad, and it is usually R1, R2 resection with nodal metastasis. So prognosis naturally is bad. Now there are a lot of papers published on evaluation of TRG. Some people use 5 grades, some use combine this 0 and 1 into 1, and then they evaluate. So they are different, but they all agree that when you have TRG3, it is worse prognosis. When you have TRG01, it will be around 60 to 40, and TRG2 will be intermediate. So this is the NCCN guideline. What we have discussed is mostly mentioned here, like they recommend universal testing for MSI by PCR or MMR-ISC, and it is recommended for all newly diagnosed patients. So all should be subjected to this universal testing. And HER2 and PDL1 testing if metastatic adenocarcinoma is documented or suspected. Now, this is very important. If sufficient tissue is available after our testing, the complete next-gen sequencing can be considered. Now, see, first you have to do the basic testing like MMR, the PDL1, the HER2, and if you have tissue, then you go for NGS, because this information is required for management of patient. And NGS, though robust, the standardization, where you're getting it done, how much is the tissue, and quality of DNA is important. So that is why NCCN recommends first you go for single biomarker testing, and then you reflex to NGS if required. Then you assess the Sievert's category, that is, now Sievert's 3 category is included with gastric cancer now. It is staged as gastric cancer, that is the epicenter more than 2 centimeter from the gastroesophageal junction, because they have the pathogenesis is similar to the gastric cancer. Now coming to my summary, role of pathology. The molecular classification maybe in future will guide the treatment, as we may identify more targets to more druggable targets, and maybe ISC markers can act as a economical surrogate, because all cannot be subjected to this next generation sequencing. And it may provide clinically useful classification. Now, liquid biopsy can be used in gastric cancer, especially advanced gastric cancer, and on cell-free DNA, NGS can be done. And there are papers which claim around 60 to 70% positive rates on liquid biopsy for actionable mutations. NTRK fusions, now larotrectinib is approved for solid tumors. It is a tissue agonist approach. So we can test for NTRK fusion by NGS or by PCR, and then treat the patient if required. Similarly, for PIK3CA inhibitors, the mutations testing can be done, and alpelisib can be given. However, all these are maybe trials. Checkpoint inhibitors are already used, like pembrolizumab, nivolumab in combination. Maybe sooner it will come as monotherapy. Nivolumab is used along with chemotherapy with or without testing for PDL1. To conclude, pathology helps in optimum management of gastric carcinoma. Histological types guide the testing, as we have already said. Universal MSI testing is recommended either by ISC or by PCR. Post-therapy response scoring is recommended, and it has to be properly done and reported because it is an important prognostic factor in managing post-adjuvant scenario. And in unresectable metastatic GC, HER2 overexpression, amplification and PDL1 testing is mandatory. NGS can be explored for additional targets once you have completed the prior testing, and stage is still the most important factor in treatment planning and patient outcome till date. I acknowledge contribution of my colleagues, Dr. Garima, Dr. Anila, Dr. Sunil, and our histo supervisor, Sangeeta, and of course, Sir Dr. Anurag. Thank you.
So thank you, sir. Honestly, I have few questions in my mind, but you have covered all those questions. So I don't have any question to ask, but I have seen few questions in the chat box. Let me introduce, we have another histopathologist from Bangladesh.
Should I stop share? Should I
yes,
stop
sir.
share?
Yes, sir, you can stop share. Okay. So we have another histopathologist from Bangladesh, Dr. Janul sir. He is working in the histopathology department, combined military hospital, CMH. So thank you, Janul sir, for joining. Sooner or later, we will hear a few words from you. I would like to request Dr. F.M. Kamaluddin. He has asked a question. So please unmute yourself and ask the question.
So, Shimon, as you mentioned that when I was writing the question, I didn't know that you will be covering the answers. So, in fact, it was quite, I have one very simple question that after coming the IEC, it is not evident for stomach, but in many issues, some of our colleagues believe that when there is a diagnostic dilemma, IHC can solve it. My generic question is, can IHC solve the diagnostic dilemma of any malignancy?
I think ISC, the role of ISC is in typing of the tumor. Like if you have a gastric carcinoma, the diagnosis is morphological. You have to first identify the tumor on H&E section. If sometimes you have doubt, like for example, in poorly cohesive, the diffuse type of Lawrence, there can be confusion with xanthoma cells, xanthomatous inflammation. So in that time, you can use cytocorrective. But for diagnosis, I think the most important thing is morphology. Confirmation, yes, and typing, yes, we use ISC. For metastasis of unknown origin, yes, ISC certainly helps in typing, but not in every case. We do get cases where we are unable to solve beyond, say, cytocorrectin positive, so it is poorly differentiated carcinoma, or CK7 positive, what they call CK7-omas. We can't tell beyond. So that is, yes, I agree.
So thank you. I asked this generic thing because, you know, in say in lymphoma, or sometimes we are taking the help of ISC in some undifferentiated carcinoma, but somehow the belief came to some of our colleagues that you cannot diagnose, do IHC, it will diagnose. So that was the message I wanted to share, that IHC is always helping us to steadify or differentiate, but it is never the replacement of the morphological diagnosis, not on even in lymphoma. So that was my first generic question. Another was that you mentioned that in MSI, the adjuvant chemotherapy is not very effective. So does it mean that chemotherapy is not effective, or it doesn't work on adjuvant? So can we use neoadjuvant in that case? That was a question came to my mind.
Actually, I asked my medical oncologist. So he said that they use checkpoint inhibitors for MSI cases. And as I've already shown, we don't have too many MSI gastric cancers in our group. I don't know why it is so, because if you see the ACRG data, it is 20%. I don't know your experience, but I mean, our cases were only hardly, I think, 5%. So what they do is usually they give checkpoint inhibitor with or without chemotherapy, I think. This is what they do. But they add usually a checkpoint inhibitor like nivolumab or pembro. That is recommended.
So my last question, that why, I mean, we are considering G junction as a separate entity when we are considering stomach cancer. I mean, we see that in total stomach, we are always considering G junction is a separate entity.
Yes, actually, in AJCC 8 edition, this Sievert's type 3, which was earlier classified with esophagus, the adenocarcinomas, because what they observed was that type 1 and type 2, they are secondary to Barrett's esophagus. They have background of Barrett's esophagus. That is gastroesophageal reflux disease, Barrett's esophagus occurs, and then you get adenocarcinoma. So they are grouped with esophageal carcinomas. Whereas this Sievert's type 3, which are with epicenter beyond GEJ, 2 centimeter beyond gastroesophageal junction, and the tumor might cross the gastroesophageal junction, but they are considered with now stomach. That is a
Thank you, Dr. Gupta. So I should express my gratitude for a very informative presentation, I will say, because I'm sure most of us was not aware of so many things are happening in stomach cancer. And I thank to my moderator, Mustafa, to bringing up these topics, because he was working on the selection of the topics. And even all targets, all the mutation are not targetable. We are using only few. But hopefully things will come up in future. Maybe today I learned that why we are using same drug to 2 patients. Somebody is doing very good, somebody is not doing very good.
Yes.
That is with some patient, some is not doing. So maybe molecular signature will give that answer. So Shuman, that's all from me. You can move to.
Thank you. Now I would like to request Janul Islam sir to discuss with our faculties. So I have seen a question from him, but now is your turn, sir. You can discuss with our colleague, with our speaker.
Janul, I want to add one thing, that because you are one of the most resourceful person in the center working. So during discussion, you should also tell us that how much is possible in our country.
Exactly.
Because we don't know. Maybe your center is capable of doing, we don't know. So this is a wonderful opportunity to know that in
Yeah, thank you, Dr. Kamal. In fact, today regarding gastric carcinoma, we have come to know the different modalities of this molecular testing. And there, there are different platforms. It includes ISC as well as there are some FISH as well as NGS. And as well as PCR. So, in fact, in Bangladesh, in most of the centers, still we are equipped with only ISC. Regarding this PCR, FISH or NGS, these will be coming up later on. But still, we are not in that way. We are not equipped in that way. So, regarding ISC for especially HER2, yes, HER2 ISC we can perform this one, and at the same time for HER2 we can perform the ISC, that is DISH, that is dual code in situ hybridization on Ventana platform. Yeah, that is possible. So and then we were practicing this HER2 staining for gastric carcinoma for long. Yeah, and then we are following the CAP protocol. We can perform this DISH as well as ISC. And
excellent.
Regarding Regarding this MMR, yes, only MMR we can do here. We cannot do the MSI due to lack of this our still we were not equipped with all the especially sequencing facilities here. So by ISC we are doing the MMR, and then all the 4 components are that MSH1, then PSM2, and all the 4 components are available with us. So you have seen this can resolve about 70 to 80% cases, and so naturally we are lacking those 20%, about 20% or more than 20% cases we are lacking in that part. So later on possibly we can cover up that part. And very recently where we started this PDL1, and there's a PDL1 on Ventana platform regarding Sir has already quoted. Yeah, in Ventana platform we are doing this. Mostly we are doing this PDL1 for lung cancer as well as for lymphoid, that is lymphoma. For gastric cancer, we have not yet done this sort of, because we have got one trained pathologist on this aspect as Lieutenant Colonel Istia. Hopefully we can resolve that issue also. So this is about definitely on ISC platform. On ISC platform we can do all the antibodies we can do here, like TP53 as well as most of the other ISC we can do in our setup in Bangladesh we can do. So naturally we have to cope up. That is what one information is that is very much required, the coordination between ourselves as well as oncologists. Dr. Kamal is playing a very important role. Hopefully this coordination will bring us to do the correct investigation for the required cases the clinician needs. So hopefully we can do later on. Thank you very much.
Thank you, Janu sir. Hopefully we'll discuss it in future, because there is a unmet need in this field. Thank you, sir. So is there any question in the chat box? I have seen that all the questions are answered. If there is any new question, you can speak out really. So is there any question from the audience? If no, then I will proceed to the next session. So sir, I have a question. It's a very might be a very stupid question, but so sometimes I think some my junior colleagues will face the same difficulties. So regarding the microsatellite instability, MSI, somebody says that PCR, and when it is PCR, it comes out MSI high, MSI stable, MSI low.
Yes.
And when we are doing the IHC immunohistochemistry, it comes with DMMR.
Yes.
So this is the same report, different type of interpretation. I got the answer, but I think you should describe it to our junior colleagues, so that if they can interpret it really.
Okay. See, MSI by PCR, it includes 5 loci, the mononucleotide. In that, they see for instability, comparing with the normal patient tissue, or by in silico analysis. So you require at least instability in 2 out of 5 loci. Then they call it MSI unstable. However, if it is present only in 1, then it is called MSI low. And if it is not there in all 5, it is MSI stable, MSS. But for practical purposes, all MSS and MSI low are considered as MSS. Only MSI high, that is microsatellite instability, is considered when there are 2 or more loci which are unstable. So that has to be kept in mind. Then by ISC, what you see is the protein expression of the genes, the gene products. So you are testing for MLH1, PMS2, MSH2, MSS6. Now there are, in gastric cancer, usually it is MLH1 methylation. Lynch syndrome is uncommon in gastric cancers. I mean, in gastric cases. So that is why they said that you can, like I showed you ACRG slide, they were testing only for MLH1. If MLH1 was deficient, then followed by MSI testing by PCR to look for MSI. So usually it is MLH1. So you will catch almost all the cases by ISC. More than 95% cases you will catch by ISC. So there is no need actually to go for this PCR based test. So usually it will be MLH1 with PMS2 loss. MSH2 and MSH6 will be intact. So you know that this is not Lynch. That is one additional advantage which you get. If you are doing PCR, you don't know whether it is Lynch or not. So that is advantage. And one thing I already said, in cases of isolated MSH6 loss, the MSI is usually stable. So it is MSS. However, when you do ISC, it will be MSS6 loss. So then you can check for the sequencing and you can diagnose Lynch syndrome. So basically, in gastric, it is not important to check for Lynch. That is why this PCR is good enough. But since we have ISC, we also do ISC first. So it is because it is in our, what we can say, the workflow of histopathologist to do ISC, and then we can easily, and it will catch 95%, 97% cases. Only few cases may slip. It is true for both.
Thank you, sir. If I am not wrong, so what I have get from your message, so if I want to see the genetic mutation, then I will go for PCR, and ultimately it comes with microsatellite instability, high, low, or stable. But if we want to see the end products of the mutant gene, that is the gene MMR gene, and we can see the end product of the gene, that is the protein, and with this immunohistochemistry, I will find out whether it is deficient or not. So the immunohistochemistry report will come with deficient in MMR genes. Yes. So for genetic mutation, go for PCR, and it will comes with MSI high-low reporting. And if it is ISC,
for management of, say, even colonic cancers, you require MSI status.
Yes, sir.
And see, that is the advantage of ISC, because it tells you additional things also about the Lynch. MSI by PCR will not tell you.
Okay, sir.
Then, of course, you have to then reflex to ISC to look for the particular gene and then do it. Otherwise, you have to do the complete set.
Okay.
So
Thank you.
By NGS.
Technically, we can say that, I mean, like colon and gastric cancer, as you said, in colon, when it is MSI low, we say that early stage, it is, I mean, MSI high, early stage good, but the advanced stage, we need to do with the PDL1. That is,
right.
We need to go for this immunotherapy. And here also, there is nothing to do with the early stage and a metastatic. When there is MSI high or DMR deficient, then we can go for adding immunotherapy to get. My question is, there was a recommendation in NCCN that if you have tissue, go for NGS. So like breast cancer, say, you know, in some situation when we are exhausted with everything, then we are looking for like NTRAC or PIK13, say, I mean, some target to play with. So is it also applicable in gastric cancer that when we, why we do it? Does it that we exhaust everything, then we are looking for it, because otherwise there is no such great target in stomach cancer.
Actually, this I discussed with a medical oncologist who treats GI cancers. See, problem with the gastric cancer, what I understood is, see, the median survivals comes to with chemotherapy for advanced cancers, even if they are metastatic or non-metastatic, is 1.5 to 2 years, usually. So when you are treating with chemotherapy, which can shows a definite response and give some months to the patient. Now, testing for NGS and selecting a target. First, you do NGS, the patient has to spend money. Target may or may not come, because See, all this data, what we have seen, if we see the frequency of mutation, it will be very small, say 5%. Say they have 50 cases, in that 5 cases might be having that. So the number is small. All this is reported, but see, we have to use it in clinical setting. You can't get NGS done for everybody, then say, oh, kuch bhi nahi aaya, nothing came. So it becomes difficult for those people. And see, first, anyway, you have to give chemotherapy to get the response. You can't do NGS, look for an experimental target which is not approved, not label. NCCN says that you can use label or non-label, but that will be in advance on chemo refractory, which are not responding to checkpoint inhibitor. Then you go for all those, I think, degree pokri.
Thank you, sir. Thank you. So, we have another faculties from India, the same institute, Rajiv Gandhi Institute, Dr. Sunil Parchisa, sir. Dr. Sunil Parchisa, sir, can you hear me?
Yeah,
Yes,
please, yeah.
Do you have any words to comment regarding these topics? Do you have anything to add, sir?
No, I think Gurudutt sir has already covered each and every aspect. I just put one question in the chat box also. I wanted to ask everybody, like who can ever take my question. Can liquid biopsy can be used in a post-operative setting to detect the early recurrence or occult disease? Any experience with the liquid biopsy?
No, sir. No, sir. Particularly for stomach cancer, I don't have.
Okay.
So, sir, we are at the end of our program. So, what's your suggestions to our audience? So, what should we do for stomach cancer regarding the histopathological diagnosis, histopathology? What types of tests you want to advise us, sir?
I mean, as a pathologist?
Yes, sir, from the pathological point of view.
Yes, yes. So, whatever biopsy comes, it should be thoroughly examined, properly reported. If it is a tumor, the grading, the type, whether it is diffuse, intestinal, or WHO classification, whichever classification you are following, follow it properly, grade it properly. If it is diffuse, whether it is having signet ring cells, percentage of signet ring cells, because in small, you may not be able to label. So exact correct diagnosis is very important, and upfront MSI testing is now done. So whichever technology we have, we should do by ISC first, give out the report, and if it is unresectable metastatic, then anyway HER2 will be also ordered, and that should be reported, and PDL1. So we are doing actually 3 tests together for all the advanced gastric carcinomas, that is MSI, then PDL1 and HER2 test. So this has to be reported properly, and the same can be basis for further treatment. And in resected specimen, which are coming treatment naive, accurate staging, especially the T staging, that is comment on serosa, the all the omental margins, and adequate nodes. As I think one question was also there, what is the adequate number of nodes should be taken out to give accurate end staging? So that should be ensured. If you are having less nodes, then resample and examine more tissue. So that should be done for all cases. And comment on margins is important. So I think this should be the message, that as a histopathologist, we should be giving all this information so that the patient can be managed optimally.
Thank you, sir. Thank you. Now I would again request Dr. Sharna, can you please poll the post again?
Yes, sir.
I would like to request all the participants to participate in the poll. It will be 30 seconds for each question.
So during the poll, Dr. Gupta said, we have a tissue block. It was,
Proceed.
so we didn't do the PDL1.
Right number is positive treatment cell and immune cells divided by the total number of tumor cells multiplied by 100. That is the combined positive score.
Yes.
So the right answer is here, that second option. Proceed.
So can we use the old block to do the PDL1 once we find a metastatic, or we need to have a fresh specimen?
Shona, next question.
Maybe we can test on the prior blocks also. There is no need for actually the fresh tissue in cases of gastric cancers. In any cancer, whatever tissue you have, you can test for PDL1. That is not is not required that you get. If it is inadequate, of course, then you have to get the fresh tissue. Otherwise, you can test. Nowadays, it maybe PDL1 will be coming on liquid biopsy also.
Thank you. Here the right answer is yes. As sir already mentioned, that even in the adjuvant setting, if there is MSI high, you should think about the adjuvant therapy. And in the metastatic setup, it has a definite role. Whatever the stage, you need to do the MSI test. So the answer is yes. So proceed to the third question. Sorry for the interruption.
It's okay. I was just trying to use the time. And this is a great issue. Sometimes we feel that maybe we need the metastatic tissue to get the thing, which is not always applicable.
Not always.
Thank you. Here's the right answer as per the NCCN guidelines. The 16 lymph nodes at least should be needed, but 30 is are desirable. So 16s are at least required. Proceed to the next question. So I think 100% audience are with the right answer. So here the residual cancer, the second options are right. The first one is the near total response, and the third one is the no response group. So the second answer is the partial response group. So thank you. That's all from poll. Now I would like to request our academic partner. I have seen Dr. Lucky Sinha is there. So say a few words. The Sanofi is our academic partner. To Lucky Sinha.
Thank you, Shuman Bhai. It's my privilege and honor to have the opportunity to give the vote of thanks. Worldwide, stomach cancer is the fourth most common occurring cancer in men and seventh most commonly occurring cancer in women. So in Bangladesh, the prevalence of stomach cancer also very significant, and thanks to Oncology Club for taking the initiative to run this continuous education program on stomach cancer. Sanofi feel proud and honored to be the part of this excellent program as a scientific partner. Dear Honorable Chairperson, respected faculty, and honorable experts, and other distinguished doctor, and my dear colleagues, greetings from Sanofi, Bangladesh. First of all, I would like to express my profound gratitude to our honorable chairperson, Professor M.A. Hai, President of Oncology Club, for blessing us by his gracious presence. RTS, thanks to Dr. Gurudutt Gupta, senior consultant and head of pathology, Rajiv Gandhi Cancer Institution, Delhi, for his excellent and elaborated presentation on how pathology can guide treatment in stomach cancer. My heartfelt appreciation to Dr. Gupta for sharing all the updates and guidelines related to diagnosis of stomach cancer. And heartiest thanks to Dr. Mustafa Aziz Shuman, Assistant Professor, Kumitolo General Hospital, for conducting the whole program so lively as always. Thanks to Dr. AFM Kamaluddin sir, Scientific Secretary of Oncology Club, for taking the initiative and engaging Sanofi as scientific partner. On behalf of Sanofi, I would like to give a special thanks to all participants for their warm presence and active participation. With all of your support, we will continue this program in future. Till then, stay safe, stay healthy. Thanks for patience hearing. Thanks to all.
Thank you, Lucky Sinha Appa. Now, few words from our academic secretary, Dr. FM Kamaluddin, whose brainchild is this program. To say, over to you, Dr. FM Kamaluddin.
I have said more than few words, so that we have a good start. Thanks to Dr. Gupta helping us to start a new session, and we hope that we will continue the journey. And this, as we mentioned, there's the secret of the success. We are only there to take the initiative. We need the support from our faculties, and we need the support from our participants. With this combination, we can go ahead. Science, and especially oncology, is everyday evolving subject. What is true today becomes wrong tomorrow. And if we cannot keep the pace, we cannot offer the best treatment of our patient. And individually to gain the knowledge is very difficult. So this is collecting effort. Say Dr. Gupta killed himself to give us the gist within 40 minutes, which maybe we should have taken 40 days, we could not find out. So this is how we are trying to make up, and we are very happy with the wonderful participation, and hopefully this will continue. And thanks to Shuman Mustafa Aziz that he is carrying the initiative forward. We are with this initiative, Oncology Club is always yes to any academic proposal, and we are fortunate, Oncology Club, to have so many friends from overseas. And today we are happy to have a new friend, Dr. Gupta, with us. And hopefully this will strengthen our capacity. And this is how we have the courage to take any program in hand without any hesitation, because we know our friends are there. They respond to us whenever we call. So thanks to all of you. And I hope, inshallah, Allah will help us with this noble endeavor. Thank you.
Thank you. Now is the time for the closing of this program. Now I would like to request again to our chairperson, Professor M.A. Haisa, to say a few words and conclude this session. Over to you, sir.
Thank you so much. I was listening throughout the lecture for the last 1 hour. Really, I have learned many things that I didn't know. Thanks to Professor Dr. Gupta.
Thank you, sir.
And also Dr. Janul Islam and participation, participants who will take part. And so I think we are now really burdened by this very proper, I think, in my opinion, confusing things. So many things are confusing. We still have to come to a concrete decision. We have to find out some new decision for policies. So how can we recapture everything and process further? Thank you all, everybody. Thanks and goodbye. Bye-bye.
Come on, result.
Thank you.
So we will inform the results. Shona, can you find out the result from the poll?
Yes, sir.
Okay. Can you please show us the name?
Yes. Here are the winners, sir.
So the Fatima Sarkar.
Yeah,
so the Fatima Sarkar. So as per the new rules, we will pick only one. That is the Fatima Sarkar. So today's winner is Fatima Sarkar. So congratulations. So you will get your prize very shortly. So thank you and stay with us. In the next week, we'll discuss on a very new idea regarding, because we have designed our topics in a very, very practical way. So stay with us and see you in next Sunday. Thank you.
Thank you. Thank you.
Bye-bye. Bye-bye.